بسم الله والحمد لله والصلاة والسلام على رسول الله اللهم علمنا ما ينفعنا وانفعنا بما علمتنا إنك عليم حكيم. طيب, good morning everyone, ladies and gentlemen. Thank you for attending the lecture today. Maybe I tried to make the topic a little bit thrilling so everyone will understand how critical is sepsis management, and inshallah our goal is to improve sepsis management in the hospital at all levels, all the way from Madam Sahar in the ER to Hussein, maybe he's not here, to in ICU, and all the way to the doctor's level as well. The reason actually I selected to talk about this topic early in the year or in the academic year is to try our best to improve sepsis care at the level before it reaches the ICU, and most of the time we reach a level of mortality that is really, really difficult to manage or control, because unfortunately already arrived at a later stage. So honestly, I should thank Dr. Siba and Ms. Teresa about having the idea to develop a quality improvement project to improve sepsis management in the hospital. And we established a project team. Dr. Siba now will briefly talk about it from the QI point of view. And then I'm a very practical person. We're not going to talk about theories. Today we'll talk about how are we going to improve sepsis management in practice. What are the forms, how we're going to do it, what are the major challenges that we will face. And inshallah we will have, bi'idhnillah ta'ala, 6 months from now, we will present the pre and post and the impact of this improvement project. So I invite Dr. Siba to please come and start talking about this.
Okay, I will be very brief. This is only just to remind you that we are going for a brief.
Sound okay? Will I give you a mic?
My sound is okay?
Fine.
Not okay. Okay. So I'll just be very brief. We are talking about the project, what the project we have in 2019, just that so we will remember all, and the guideline. We have to have at least 5 guidelines during a year, updated or new. Okay, and this is what we are talking today about, is the sepsis guideline embedded in the project. Always our improvement is taking the plan we do, then we study what the result, and we act on the larger scale. Our model that we are talking about in this project is model for improvement. And our project for this year, if we look at the improvement, we have a proactive, we have reactive sepsis, and we have performance improvement according to the data we found, and this is what we are going to talk about today in sepsis.
Okay, thank you, Dr. Siba. I think I have it over here. Okay, so the first step to really handle this problem and tackle it really well, we established a team and named it Sepsis Task Force. The task force members will actually represent all the stakeholders that are responsible in sepsis management in the hospital, which include the ED department, nursing office, ICU, inpatient representation by Dr. Ahmed Saad, as well as infectious diseases, and Dr. Nicholas from infectious diseases and stewardship. And inshallah we will actually create, and who else? Pharmacy, Dr. Islam and Dr. Mahmoud, as well as Dr. Ghazi Damanhouri, which unfortunately one of the major challenges we have in management of sepsis right now are related to pharmacy and lab. For example, we found by just preliminary analysis there is significant delay in giving antibiotics despite being ordered in the right time, but unfortunately we don't have the antibiotics available in the emergency room, so they have to ask pharmacy. This takes 3 to 4 hours. We analyzed just one patient kidder randomly. It took 6 hours to receive the antibiotic despite being ordered in the same time. So now, inshallah, with the Sepsis Task Force, we are tackling all these challenges. One of the challenges, for example, we found that we order lactate on time according to the guidelines, but because the point of care test cannot be done in the ED or in the ICU, has to be sent to the lab, it takes 4 or 5 hours. So the management completely will start without the lactate supervision and guidance. And we will outline all these agendas. We will go with the KPIs, and then we will follow it up and go from there. The task force, as I mentioned, will actually represent all the domains in the sepsis management. Now, the project will not include only emergency room, because also we as ICU, as you all know, we are responsible with RRTs. And honestly, I received too many feedbacks from our registrars that the patients, unfortunately, were not managed properly as sepsis. And we're talking about basics: fluid resuscitation, antibiotic administration, ordering proper labs. And unfortunately, the patient reached an RRT level where he is already in the shock state. And the patient should have been managed much, much better in the ward. And honestly, regardless of what specialty the patient is, because sepsis management is actually everyone's responsibility. We as ICU, we manage the critically ill ones of them, but everyone has to manage sepsis properly, at least in the 1 hour. So what are we trying to accomplish with this sepsis task force? One, which is really important in our hospital, is early identification of sepsis and septic shock. And this will actually be mainly through increasing the awareness, more awareness to the RODs, and we will have a lecture only directed and targeted to them, as well as management. The second thing, unfortunately, we noticed that management depends on who's on call, who's the registrar. Anis Sindi like to give Tazocin, Dr. Ahmed Saad like to give meropenem. And unfortunately, sepsis is one of the most common illnesses in medicine that is so standardized. There is very clear sepsis guidelines. It tells you what to do and what not to do. And honestly, simply, we just need to implement it. So to make completely the personal and customized treatments really, really, really selected. The third one is, as we said, the standard sepsis clinical care, and the sustainability. Is not like 1 or 2 patients. We will have KPIs that we will keep monitoring, and that actually will help us to implement a proper sepsis treatment. At the end, we as physicians, maybe more with quality and labs and so on, we care at the end about the mortality in our patients. So this will be #1 KPI for us. We have a lot of data. Dr. Asiba, thankfully, in her department, collected a lot of sepsis-related mortality and so on. But we want to refine it and make it target to the new KPIs that we actually took it out from the sepsis guidelines KPIs, adjusted by Apache score, by the age, by the diagnosis, by emergency versus inpatient. And sometimes actually we see ourselves even better, because at the end, high Apache score septic shock patients, they have 50% mortality. So we don't expect them to really do better than what the standard and best practices actually say. As far as we compare our rates to the standards, then we will be fine. So just to make it quick and short, our goal, hopefully, inshallah, to reach 100% compliance to all these KPIs. But then if we find the weaknesses, then we can work and improve. The outcome measures will be more listed in detail about the ICU admission from the ward as septic patients, if they're actually yes or no, the turnaround time of transferring septic shock patients to ICU, length of stay, readmission, post-operative sepsis. All these will be KPIs that, with the support of quality department, we will collect and then come up with good numbers. How we're going to do them, improving surviving sepsis. There is a score called Sepsis Early Warning Score that actually Mr. Reza will talk about today. Again, it's part of the Surviving Sepsis campaign. It's in their guidelines. They will actually simply, we just took it and we will implement it exactly as it is. And also establishing the onset of assessing septic patients. Now, treatment-wise, there is actually something now already implemented called 1 hour bundle. The 1 hour bundle is simply, we will have it discussed a little bit in more details, what the first responder should give right on. No even thinking, very safe, evidence-based, no excuse whatsoever not to give this 1 hour bundle treatment options that actually will survive or make septic patients survive even more. And then the 1 to 24 hour, we will discuss it more in details and the pathway. So now I'll let Mr. Reza talk more about the sepsis score. Where is the mic? here. Yes.
Good morning. So in May, nursing started their activities with the sepsis project, and there's two main points for nursing. We are at the front of it, which is the early and accurate identification of the patient in sepsis, and we're at the end, which is that the nurse has to carry out the physician's orders in the time that is specified in the literature that has the most impact for patient care and patient outcomes, specifically reducing the morbidity and mortality of the patients. So nursing, we will do the correct assessment. So as you know, nurses spend the most time with the patient. So what nurses see and what they decide to assess and how they assess it and what they escalate up to the physicians and how timely we do it is what really impacts patient care. So we are going to assess the patients at specific intervals of their hospitalization. So I think it's here, which is that when the patient arrives into the ED, when the patient is sent from the ED into the inpatient area, we will capture patients who are in the clinics who are being admitted for any suspected or confirmed infection, and we also do it with our RTs and any change in condition, specifically the post-surgery fever, which we have to work on. So then the physician decides whether they will implement the 1-hour sepsis bundle. And I will leave the last two for Dr. Sami, I think, for the ER. So this is the sepsis early warning scoring that we started. And the most important thing is that the nurses are quantifying their assessment. There's 3 benefits for doing this. One, it actually levels the competency of the nurses. So if I'm the ER nurse and EHAB is an ER nurse and Dr. Iyad has a patient, if I'm using the score, but I've only worked with the hospital for 5 months, but EHAB has been here for 6 years, it levels the assessment, which means that the patient shouldn't go to the ICU and survive just because EHAB happened to be his nurse. Does this make sense? Okay. So what we do is the nurse simply asks if the patient has a suspected infection or confirmed infection, and then we're using 2 evidence-based scoring from the Surviving Sepsis campaign. One is the QSOFA, which is a sequential organ failure assessment, and the SIRS. So each of them has to have a trigger point of 2. So once the nurse quantifies and puts a 1 for the respirations are greater than 22, or the white blood cell count is greater than 12,000, if there's a 2 for either one of those scoring, she or he will then go to the organ dysfunction score. So any of a yes for any of these indicates that there's hypoperfusion for the patient or possible organ dysfunction. And when the nurse has a yes to that, she or he will then say that there's a positive screening for sepsis. She will notify the physician. She puts the time that she notifies the physician, and the physician decision is whether or not to activate the sepsis bundle. This is the sepsis bundle. It's posted on all the units, and it has the 5 points that will go to Dr. Anise next. And the nurse doesn't actively initiate any of these. She or he only does it on the physician order, and they can all be modified. And because it's a Surviving Sepsis campaign, we want the patients to obviously survive sepsis, but when we did the lectures for the nurses, we named it Catching Sepsis, because we want the patients to survive the sepsis, but we want the nurses to catch the sepsis. So I will give it back over.
Yeah, thank you. I have mine.
Okay.
Thank you. So again, this is just an example of how things, we can turn it into more practical than just theoretical. Now, this is taken from the Surviving Sepsis campaign. It's not me who did it or anyone else. So first step, of course, this is only for suspected or confirmed. For emergency people or room, they will not do it for everyone. Only for patients where sepsis is actually suspected. Measuring the lactate, and we have challenges. We should admit that we have challenges on all of them. For example, is the lactate level. Obtaining blood cultures and before administering the antibiotics, because that's unfortunately is another challenge. Administer the appropriate antibiotic, then the fluid resuscitation. Unfortunately, we have some kind of phobia of giving too much fluids, although always sepsis management, fluid is #1. And most of the time, unfortunately, this is undertreated, especially on the first hour management. The last thing is actually to apply the vasopressors, and usually, at least for now, this is I recommended to Dr. Asiba, is not to give inotropes in the ward. Please, Alan, we don't want to take any risk to have any complications happening from inotropic support, but from the form and the template of the sepsis management template, You give only, we will talk about it more, but please do not start inotropes in the ward. RRT definitely will be activated, but if you reach a level where the patient is not responding to what we wrote in the form, call RRT. So this is something we would like to avoid, at least for now, until we see how it goes. So this is the form. It will be replacing another form, by the way. You know, I hate a lot of paperwork, but I asked Dr. Asaba first question when we talked about this. This is an additional paperwork. She said, no, you will remove the care plan, and she will put this instead. Because I have to convince my registrars as well. But honestly, we really need it because sepsis is not well properly managed. So the first part of the form is we just need to know if the triage was done and timely, and then if the sepsis and septic shock, the screening was done, the one Mr. Reza mentioned, we were notified or no. All these KPIs, as you can see, will actually help us to know what were the problems during the management of this patient and how we can fix it. Now, why we put patient immunocompromised or no, as you all know, management is completely different. Febrile neutropenia is totally different than just community-acquired pneumonia. This is the 1 hour bundle. Into more practical terms, this is the form. This is the form. So these are very simply the goals that will be filled at the end. But let's move to the practical part here. Serum lactate. Now, as you can see, this section is for the physician. This is for the nurses. So actually, it's one form for both. So the physician actually should just simply order by ticking these requests. And IV stuff for serum lactate, blood cultures, exactly as the one we saw in the picture. And then even we tried to make it simpler. 30 mL per kg, how much I'm going to give? We said no. You just need to tick. You want normal saline or Ringer's lactate? You want to give 500 or 1 liter, and over how long? So a tick box, tick, 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 and sign at the end, and that's it. Time initial fluid completed to resolve hypotension, and then broad spectrum antibiotic, and we'll move on to. This is the antibiotic list. Now, I did not make this list. Even Dr. Ahmed Saad, Dr. Nicholas, they reviewed, they gave recommendations, but at the end, we actually took it from guidelines and recommendations that are best practices. Yani, to avoid having anything personal or customized, aggressive or undertreated, no. Now it's standardized. So if the sepsis, and let's say in ER, source is still not known, hypotensive, tachycardic, febrile, likely sepsis, then you go with these checklists. Vancomycin 2 gram stat. Now this is only the 1 hour bundle. Yani stat dose is not a regular dose. Vancomycin plus one of the following, either meropenem, 1 gram or 2 gram. If the patient looks shocked, then we would give 2 gram, or imipenem or tazocin. Our goal is to have them available in the emergency department on spot. Now, we had a lot of discussion with whether this will make the antibiotic actually abuse more and more. No, because we will start to go back again and see who used it and why, and was it appropriate or not. So this all will be studied.
The first one to be vancomycin, and we will choose one from the 3.
Yeah, well, not the first. I mean, it's both.
I mean, vancomycin
Plus one off.
So it will be 2 antibiotics.
2 antibiotics on spot. This is for the unknown source. For the CNS, as we all know, CNS antibiotics are very well standardized. Vancomycin, ceftriaxone, the dosing. This is only stat dose. UTI also, you have amikacin times 1 plus meropenem. There was a debate whether we should plus or. Dr. Nicholas, Dr. Ahmed said, no, let's make it plus for now. And then maybe with the support of Dr. Yusra, we'll see the resistance strains and so on, and whether we can just maybe limit it to meropenem and then check. Now, single dose of amikacin, regardless of kidney function, will not harm. Single dose. This is only single dose order. Then for the pulmonary, we found that we have to split it because this form is not only emergency room. This is maybe Dr. Iyad patient who's been here for 3 weeks and now he's developing healthcare associated. So healthcare associated is different than community acquired. Ceftriaxone plus azithromycin or only levofloxacin. And hospital acquired exactly as per all the guidelines we know. Hepatobiliary is again 1 dose of tazocin and then the rest will come. If there is anything selected antibiotic, then we can discuss it and see. طيب. When do you call us? When do you call ICU? Honestly, as you all know, ICU is cost, ICU is infection. As maybe we all hear from Dr. Huda that we have sometimes inappropriate ICU admissions, unnecessary, let's say, and we want to minimize for the patient's sake, not only for the hospital's sake. So all these actually are important. Unfortunately, I should say it, which is for now is okay, but now it's time to standardize. We get called more than it should, simply because the primary registrar is not doing what actually he's supposed to do. So we want to make it more standardized, and also for our KPIs. We want to know why patients in sepsis go to ICU. Is it because they actually match a score, or is GCS, or pH, or MAP, or? Now the MAP, after 1 hour of IV fluid of more than 1 liter. يعني مو يجيني واحد يقول لي I give 200, 1 liter did not respond, call ICU. This is inappropriate. We will not refuse patients, but definitely we will come back later on and ask why we were involved with improper management. If no, then let's say this is a patient of Dr. Ahmed in the ward, given 1 liter of fluid, blood pressure improved, antibiotic given, patient does not match any of these criteria, then just keep managing the patient. There is no need for ICU whatsoever. But definitely, we are available. This is 1 page. In reality, this is a 1-page form, tick, tick, tick by the physician, stamp, signature, and then the role of the nurse is to make sure all this are done in timely fashion, as well as with follow-up. Any question about the 1-hour bundle? Because this is really important. Dr. Ahmed.
I talked with Dr. Oseba regarding cyclovir, because must be given in the first hour also. Better to be added to the vancomycin plus in the box of the...
Sure, why not? Yeah, well, usually, Doctor, if there is anyone with acute CNS, possible CNS infection, we add antiviral because it could be herpes.
We list the others.
This can be added. Yes. Dr. Ahmed, at the end, I need to emphasize, please, for all, we are all stakeholders of this. It's not only me, and I'm just trying to facilitate and moderate, but it's our responsibility, all of us. This is very good observation, Dr. Ahmed. Honestly, we said, let's start with the bacterial ones. If you notice, then with the next version of the form, in 1 month, we can just add it. This is not Bible or Quran. We can just keep updating. Dr. Riyad.
Thank you. Definitely, there is a fear of giving fluids in this hospital. Even,
yes.
Let me frank with you, even in ICU.
Yes.
Management, for example, management of acute pancreatitis requires 1 liter of Ringer lactate in 1 hour.
True.
And then we have to give 5 ml per kg, 50 ml per kg per hour continuously. So we have to give sometimes 300, 400
yes.
per hour continuously. Yes. And that doesn't happen in most of the time. Now, my question, where does in your algorithm fit the central line placement to give them confidence so they can give fluid what is needed?
Okay. Very good question. So the first one, we will not talk more disease specific, but of course, pancreatitis is like a chemical burn. So the way to treat is fluid. But let's say this is an example. In the ward, your registrar could not give the fluid he wants simply because there is no access. So this meets ICU criteria. So immediately notify us. We will manage with central line insertion and take it from there. No, but this is actually very important because access is an issue, especially in these shocked patients. So this is one of the criteria. Now again, let's say after 1 month, any of you can call me. Let's say, Dr. Anis, we have issues that actually we should modify or edit. By all means. This is not solid that we can discuss and keep it more and more. And at the end, evidence wins. It's not only me or Dr. Oseba or Mr. No. It's everyone's actually guidelines.
Who decides to give whatever? Is it the consultant or ER?
No, the registrar. Well, let's say the first responder, Dr. Azam.
The registrar.
Yes. The job of the registrar. And honestly, we don't want to make it as a military, but I cannot give an excuse for any registrar in any specialty not to give the 1 hour bundle. There is no excuse. They're extremely basic stuff. What we see right now is, unfortunately, they're dumping the patient on ICU registrar by RRT, just simply because يعني احنا we're happy to manage, but this is your job. And this is neurosurgery registrar, this is, طبعا if the consultant was already at the bedside, هذا موضوع ثاني, بس إنه registrars, almost 90% they are the people responsible. طيب, because of time, I think we have to move a bit faster. So this is the second page, this is us. If the patient reach ICU, it's us. If the patient improved after the 1 hour bundle, then no, this patient actually can be managed by the service provider. Or if the patient is in the emergency room, likely will be admitted, and then it depends where to go and will be managed. So the first day or 24 hour, of course, we want to maintain blood pressure normalization. Was it met, not met, and why? And measure urine output. This is already being done, but now we're documenting it more and more. بالنسبة لنا هذه يعني this is our bread and butter management in sepsis in the ICU. Because of time, we will not go through it, but as you can see, again, the doctor just tick, 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 and the nurse will just document if it was done or no. This will give us a lot of information down the road if we're managing sepsis well or no. Remove central line as a source of sepsis. Remove Foley's catheter. Do you need to replace? Yes and no. The role of vasopressin with the new evidence. DVT prophylaxis. Yani comprehensive checklist. Arterial line, mechanical ventilation. At the end, the physician will sign 12 hours and 24 hours. This is the one after, which is yani, much easier. It's just a continuity of the management. Was the infectious sources identified? Reassessing the source, this antibiotic, can we narrow it now, and so on. Nutrition therapy, physiotherapy, and then the signatures. This will be the last section in the form. Was the patient identified to have severe sepsis or septic shock, ED, ward, ICU admission, stay, the code status, ICU discharge, hospital discharge, what is the status? This, inshallah, in 6 months from now, we will collect all this information and present it, and see how we can make it even better or even make us more focused. Yani, let's say, for example, we found, nothing personal, but we found that internal medicine have actually certain issues in managing septic shock patients compared to cardiology. So then we need to talk more with the registrars is what are the problems and how we can give proper training. طيب, at the end, again, I'm just the facilitator. I would like to thank everyone, all the way from Dr. Asiba to the nurse director to the resident registrars, Dr. Faraj, and everyone. And please, again, this is not only me, this is not ICU, this is everyone's responsibility. And honestly, when was the title Hunting the Serial Killer, sepsis is a serial killer. It kills everyone. Neurosurgery, cardiology, GI, pulmonary, it kills everyone. So that's why, please, we need to tackle it really well so they don't reach us in ICU where it's actually too late. Thank you very much. I think there is a certificate or طيب, any questions? بعدين الدكتور أحمد تفضل.
Regarding point of care testing, to have an available machine in emergency or an ICU, this is an emergency. By the top management now, this machine should be available either in emergency room or in ICU, because already we suffered a lot from the lab in the last few weeks. The lab, the chemistry is shut off for a few hours. Yes. Patient with pulmonary embolism waiting for 6 hours, waiting for creatinine to do CT angio. This is a catastrophe. Also the lactic acid. You are pointing to us now that this one of the diagnostic criteria is lactic acid above 2. What about one of the patients of mine now in telemetry, in 467B, patient bilateral pneumonia, myocarditis, he's 27-year-old. The lactic acid came back after 4 hours. In Cairo University, the intensive care, they have point of care testing. You can have the lactic acid, creatinine, electrolytes, and everything in 10 minutes. Machine can give you an answer in 10 minutes.
Yes.
We are much more advanced than the Cairo University. There's a small machine to be available in emergency or in ICU to support us during the off lab.
Well, Dr. Ahmed, definitely because of time, I did not really mention any of the challenges or the agendas that we have. But that's why we created the task force. We will have agendas, regular meetings, and I'm sure Dr. Arfan, Dr. Huda will support us. Dr. Arfan knows many of these issues, and the only thing is just we keep pushing and pushing. At least now we show that we have something more organized, and then Dr. Ghazda Manhouri is aware. Unfortunately, he couldn't make it today. Dr. Arfan told us about the Roche and the point-of-care machines. I think they will arrive soon. So inshallah, this problem will be solved. Dr. Islam kindly now is aware about this antibiotic delay, because maybe the sub-stores or the in-patient pharmacies will solve this problem, and so on. Yani, inshallah, their challenges are there. Passionate to improve it, inshallah, is there. And I'm sure Dr. Arfan, Dr. Huda will support all this. Because this is pure medical now. Yani, this will have an impact on patient outcomes. Any other questions? Dr. Majdi.
Fixing the antibiotic for some indication like community acquired pneumonia, you may have some allergy for the patient, you have previous use, so you have to open another choice. If these two antibiotics are not suitable, supposed to have the freedom to start another one.
That's exactly why we left others.
Yes.
في آخر أي شيء في الانتيبيوتيك في فراغ فاضي. Let's say زي ما تفضلت هو allergic لليفوفلوكساسين وكل الثلاثة اللي حطيناهم allergic to it. Then let's say for example you decide to treat with whatever يعني moxifloxacin with ceftazidime. Just write it down, Dr. Majdi. We have no problem. بعدين in the comment, just احنا for us to review later on, you just mention. And the patient is allergic to all of the above. That's it.
The main problem for the antibiotic, I gave a lecture 4 years ago about the pneumonia as an emergency, and you have to start within 1 hour if severe, and within 4 hours if mild to moderate. Up till now, the dispensing of antibiotic is very late. The main problem is to dispense the antibiotic from the pharmacy. Usually, some cases taking more than 4 hours to give the antibiotic.
Problem is still there. Dr. Islam now is aware about it, and I think he has something to mention about this. Yes, there is a problem about this. True, Dr. Islam. Without
identifying that it's sepsis, I won't be able to know that it's urgent order except if I identify it. We solved this problem in the ER by placing the medications there. Right now, the inpatient is out in the sidelines for the ER. For the ICU, we have a pharmacy special for the ICU. So I think this.
يعني الآن Dr. Majdi, this will be your passport to dispense the antibiotic in timely fashion, because Dr. Islam mentioned in one of our meetings that they don't know if this is really emergency or just a routine. Now if he see the form as pharmacy, hopefully inshallah, it will be dispensed in a timely fashion. Because if it will not, it will be captured. And then we will actually know why it was not given.
Secretary, as regards the definition of all kinds of shock, it depends on the hypotension and tachycardia, altered mental status, and the elevation of the serum lactate with damaged tissue perfusion.
No, yes.
In patient with septic shock, the story is different because you know most of this patient from the start they are in shock stage because of the abnormal tissue perfusion and presence of hemodynamic
vasodilatation.
So what are the most specific tests as a biomarker to guide the clinician or the nurses in the ER to reach the definition of shock in hemodynamically stable patient? For example, patient who came by pneumonia.
Yes.
And his blood pressure 140 over 80. And the mean, it's okay, 70. But the patient in shock stage.
Well, in shock stage with normal blood pressure, you mean?
Damaged tissue perfusion in septic shock.
Yes. So, طبعا, at the end, the best biomarker is bedside assessment. يعني I can't actually standardize certain يعني things because it varies. وإحنا في الforms هذه which are already يعني best practices, we can't make it for such patients where يعني إنه صار automated يعني ما هو robotic اللي هو جاء tachycardic حط لا. في symptoms, في clinical assessment, but there is no يعني certain biomarker that will actually say sepsis yes or no. Shock state is shock state, very clear. But if someone comes tachycardic, febrile, and cough and already phlegm coming out, this is sepsis.
DVT here it will have a role because you know there is significant shunting in patient with septic shock?
Well, one VBG, as you know, there are too many causes of acidosis. If it's not related to lactic acid, is it related to DKA or related to renal failure and so on? So even, يعني again, this could be something personal, but this is actually what the guidelines and the 1 hour bundle is listing. Fine.
You mean to say, if, for example, I suspected intra-abdominal sepsis, I won't wait for CT abdomen to disclose the presence of an abscess, but I will take antibiotics immediately,
yes,
without waiting for the confirmatory tests.
Well, hopefully you don't the patient does not reach ICU at the
CT, MRI, MRI with gadolinium.
هذا كله diagnostics دكتور هشام.
Yes, I'm not going to wait for all these
No.
confirmatory tests.
No.
I will give.
This is the whole idea of the 1 hour bundle is to capture before all this routine diagnostic testing happens. Let's say acute abdomen, tender, rigid, maybe recent procedure or known to have gallstones, a little bit jaundice, tachycardic febrile. Yeah, this is likely hepatobiliary, or if the kind of ischemic gut risk factors and so on. But that's, yes. Give a stat dose, give 1 liter bolus, and do the rest of the workup. That should be fine. Of course, طبعا, yeah, definitely, yes.
شكرا دكتور أنيس.
شكرا جزيلا.
وننتهز هذه الفرصة عشان نكرم أخونا الدكتور أحمد نجيب خليل was chosen to be the physician of the month. فنحيي جميعا. نيابة عن إدارة المستشفى نقدم له هذا طبعا في أيضا مكافأة مالية معها ومكافأة أخرى في الايفالويشن فورم حقه، وإن شاء الله يعني جميع الريجسترارز يبدأوا كده يشدوا حيلهم to be يعني competitive in the next month. شكرا دكتور، جزاك الله خير. شكرا. طيب